first was just open. Let me help you.
This one. Yeah, this is fine. Can I start? So good evening, dear friends, respected Dr. Reddy. I was at the airport as usual when I got the message from Ram Mohan that after 4 days I have to give this talk here on biomarkers in stroke, unmet needs and future directions. It's a very futuristic talk, and Ram Mohan is very futuristic. Right from beginning we know. And another person who is very futuristic here is Professor Reddy himself. In fact, I remember I was in his home when the ticlopidine was banned because of the hematological side effects, and I told him that ticlopidine they are going to withdraw from the market, now it will be clopidogrel. And he told me, but the clopidogrel also has hematological side effects. I told him, who told you? He said, in the New England Journal 3 days back. I said, where is that? He said, wait a minute. He went inside and showed me the copy. There was a movie, Kagaz Ke Phool, by great actor Gurudutt in 60s. It was a CinemaScope movie. It was a big movie made on a big budget those days, and it failed miserably. And it put Gurudutt into so much of depression that he committed suicide. And the reason they gave for its failure is that they thought the movie was futuristic. People couldn't understand it. Today, this movie is thought as one of the classics and is taught in all the cinema schools and colleges of the world. Although at that time nobody understood this. To know the biomarkers of stroke, we need to know the biology of stroke, or rather pathobiology of stroke. And stroke is a disease of blood vessels. Till a certain age, the blood vessels remain normal, nice. But then these plaques develop at various places. In the heart, clot develops, thrombus develops. But in the vascular tree, plaques develop. They develop in aorta, they develop in carotid artery, and they develop in the vessels inside the brain. And for most of the life, these plaques don't disturb a person because they are very well covered and protected by a covering from outside, a fibrous covering. But then something happens at some time that fibrous covering breaks down because of some compounds circulating in the blood. We call them metalloproteinases. Now, what causes metalloproteinases is a question in itself, that's a separate topic. But plaques, as long as they don't rupture, there is no stroke. The problem comes when they rupture, when they ulcerate, and then they embolize into the brain and the stroke happens. Now, why do these plaques and clots develop at all? These are the risk factors: hypertension, cigarette, diabetes, lipids, obesity, alcohol, smoking, atrial fibrillation, prothrombotic states, cardiovascular disease, and genetic predisposition. Because a lot of people with all these risk factors don't develop plaques, don't develop stroke. So there is a genetic component. Finally, a disease is a result of an interaction between genetics and the environmental risk factors. We have been involved in stroke genetics here in Hyderabad itself. In fact, it was 10 years or 15 years ago when the stroke gene was discovered in Iceland, Antarctica, and they called it STRK1. It was an isolated stroke gene, only stroke gene. You know, even when you remove the influence of hypertension, diabetes, everything else, this was thought to contribute to stroke. But then it could not be replicated in all parts of the world. It could be replicated in Japan and some parts of China. And surprisingly, in Hyderabad, when we did this genetic study, it was an ICMR funded project, we found the same gene here. In fact, this gene consists of a component called phosphodiesterase 4D. On stroke gene, there is phosphodiesterase 4D polymorphism, and it was found significantly in the population of Hyderabadi Indians, and it was published. But whatever may be the mechanism, whether it's a large vessel disease, whether it's a embolic disease, whether it's a small vessel disease, the final pathway by which the blood circulation is stopped is thrombosis. And it is this thrombosis which causes stroke, which can happen because of all these mechanisms. And when this thrombosis happens, when this ischemia happens, body tries to fight it by collaterals or by intrinsic thrombolysis. Body produces its own thrombolytic substances. When these things succeed, we call it was a transient attack. We call it transient ischemic attack. And when it fails, we call it a stroke. So basically both are same, only in one it recovers, in one it doesn't recover. But stroke itself also is not as simple as it seems. It undergoes through a certain process of evolution after the thrombosis occurs. If you look at this, take it from the point 0, that is time 0. At that time, normally the cerebral blood flow is 50 ml per 100 grams per minute. And once it comes below 20, there's a functional impairment, below 20 ml. Once it comes below 10 ml, there's a membrane failure. And once it comes to 0, there can be death of the cells. But this also happens, there is no immediate death. It happens along the time. So up to 25 or 30 minutes, we can save the brain. It is dysfunctional but not dead. But from 30 minutes onwards, as you can see, the single cell necrosis begins. By 2 hours, almost a lot of it is already damaged. There's a lot of necrosis in this by 2 hours. And only this much is remaining. And after 3 hours or 4 hours, we are trying to save only this much, what we call penumbra. Therefore, if we have to save stroke patients, we have to act in time. We have to act within first half an hour or 1 hour because of the evolution of the acute ischemic stroke. Now, when this stroke happens, when this infarction happens, what happens? It is an interaction between all these substances in the brain, and all of them are important. Initially, we used to think it's only blood vessel. But blood vessel is only one player. The central one is blood vessel. It is surrounded by neuroglia. Glia is thought to be very important, taking part in this stroke damage. Then there are astrocytes. Then there's a matrix. So this is the whole scenario when a stroke happens. As soon as there's ischemia, the first thing which gets activated, surprisingly, is microglial activation. If there was some way by which we could stop this microglial activation, we could stop stroke damage. Till now, we don't have anything. We don't even understand glia very well. We thought glia means only glioma, but no. There's a lot in glioma, a lot of activity. The stroke itself is, the whole cascade starts with glial activation. Within 1 day, there is a leukocyte infiltration, there's a lot of inflammation. By 3 days, there is macrophages. And all this is controlled. The response of these leukocytes and microglia and macrophages is controlled by the inbuilt genetic machinery in each and every cell, which you can see on the top side. There are genes, and these are these names of these genes, cytokine adhesion molecules and NF, IRFI. So they control. They are part of the apoptotic machinery. They control how much of damage will occur. That's why you see 2 stroke patients, 1 person recovers very well and 1 person doesn't recover. So it's the interplay of so many biological factors, all of which can be variable between people. Believe me, when a stroke happens, when ischemia happens, when infarction happens, it's like a full-fledged Mahabharata happening. There are so many players within it. Big players, small players, elephants, horses, chariots, swords, blood, damage and damage. This is stroke. If you want to know what is stroke, this is stroke. War going on. Now replace them with leukocytes, polymorphs, macrophages, adipocytes, and that is this. Translate that picture into this picture. There's ischemia. There's the axon terminal release of glutamate and excitotoxins. Those excitotoxins are just damaging the neurons. There's the floodgates of kainate receptor and AMPA receptor and EMDA receptor open. Sodium flux is in, calcium flux is in. There's the failure of ionic pumps. There's increased cellular sodium, calcium, chloride. There's the stimulation of phospholipases, increased free fatty acids, arachidonic acid. all the free radicals, they are causing all the havoc. And this is the genetic machinery which you can see inside the nucleus. Even the genetic machinery is damaged and attacked by these phospholipases and by this thing. So therefore oxygen radicals, mitochondria are damaged. And what is the net result? This whole thing is the inflammation going on, stimulated by the ischemia. The net result is injury to the cell membrane. When you see these citicoline and all, they claim that they protect the cell membrane. They are not completely correct, but that's the idea they sell. But it can't happen. It's not that easy. Because you have to control each and every component, each and every soldier, elephant, horse here. That can't happen. This is again, I'm coming back, I'm showing in between the world literature, in between our own work. This work was done in Begumpet, in Institute of Genetics with one of our collaborators from our stroke patients and published in the International Journal Inflammation by our genetic collaborators. C-reactive protein and nitrous oxide levels in ischemic stroke and its subtypes. Obviously, C-reactive protein is an inflammatory marker. So when you take these stroke patients and take their blood, there are huge quantities of C-reactive proteins compared to the controls, which only means that the inflammation is taking place. And the more the C-reactive protein, bad the prognosis. And it depletes the tissue of its nutrients. Zinc, very important thing. People have seen zinc, magnesium, selenium, everything becomes less. This study again was done here. Depletion of serum zinc in ischemic stroke patients. So this is the sequence of molecular events, what happens in stroke. Mahabharata lasted for 18 days. This also lasts for 18 days. Starts from zero, ion channel changes, activation of voltage channels, glycine release, glutamate release, nitrous oxide. Nitrous oxide is the villain. It's the worst thing. If we can remove and control nitrous oxide, 80% damage will not occur. But we are not able to do that. So within 3 hours, the damage is over. After that, the thrombolysis and all is just a formality. It won't help. There's already damage. Then next 15 hours, there's inflammation for 5 days, free radical generation, and by 15, 16, 17 days, the damage is done. Then it's only rehabilitation. So this is the overview of stroke, friends. Stroke pathophysiology, something which develops over decades. It is not a cerebrovascular accident. The foundations of it are laid from the age of 15 years onwards. So hemodynamic changes happen when that plaque develops. There are hemodynamic changes that happens over decades. Then for years there's a metabolic changes. That means there is less blood going, but it extracts, tissues extract more of oxygen. More of oxygen extraction ratio. Still the patient thinks he's all right, there's no problem. He keeps on drinking, smoking, enjoying. He doesn't know that he's living on a precipice at the edge. And then within hours, he gets the stroke. But there is still a chance of penumbra and all, and within minutes he gets a damage. So this is the whole snapshot scenario of a stroke, something which develops over 30, 40 years. Then the result is within 1 or 2 minutes, finally. Now we come to biomarkers. Biomarkers which will identify the people who are at risk of getting a stroke so that they can put their act together. And biomarkers after the stroke, which will help us either to diagnose or to treat the patients. Before the stroke is genetic, cardiac, imaging and blood. That's our hope, that if we take these samples, we can identify people who are at risk for stroke. Now, this is again our own work which is already published. These are various gene polymorphisms, and in this you only have to give a blood sample, and if you find this PDE4D, which is the stroke gene found in Iceland and also found here, then you are at a risk of intracranial disease, extracranial disease, small artery disease. All kinds of strokes can happen if one has this polymorphism. If one has a AS polymorphism, he will get intracranial disease alone. So therefore, each person has a genetic portfolio. So if you know your genetic portfolio, it helps a person to understand how much at risk he is. Then what are the cardiac biomarkers of stroke? Atrial fibrillation is the biggest biomarker. If you know a patient has atrial fibrillation, he is 17 times at risk of getting a stroke compared to a non-AFib patient. And in fact, ECG helps here. I think ECG is a biomarker, because clinically sometimes we can miss. This patient clinically we missed AFib, it looks almost regular. But when you do the ECG, it looks abnormal. Myocardial infarction is a biomarker. Because when you have a myocardial infarction, you have a propensity to develop clots inside the heart. And any patient who has a myocardial infarction, he is at risk of stroke more so in the first 6 weeks, little less in the 6 months, but almost always at some risk throughout his life, because there are some, the myocardial wall is damaged. Sick sinus syndrome, tachycardia, bradycardia syndrome, if we detect it, it's a marker for stroke. They are at high risk of developing a stroke. And these all things which can be detected by echocardiography are high risk cardiac sources. Mitral stenosis, prosthetic valve, mural thrombus, ventricular aneurysm, echinacea, dilated cardiomyopathy. Next is, after the heart, next is vessels. Now, you know, vessels are large vessels and small vessels. Here you can see carotid artery. This is an extracranial large artery. And on the right side, you can see internal carotid artery, intracranial, and MCA. So there is an intracranial example of a large artery stenosis, that's an extracranial, and both of them are markers of stroke. At any time they can get complicated, and anybody who has these has to be aggressively treated and monitored even before the stroke develops. They are atom bombs waiting to be blasted unless action is taken to control them. This is our own study once again. It's again an ICMR project. In fact, this is our first ICMR project between NIMS and ICMR, prevalence of asymptomatic carotid disease in our own population. And we found that 5% of the population who come to our general OPD for other things are having, if they are more than 40 years of age, they are having more than 50% stenosis, which is significant, 5%. And 18% of the people, intima media thickness is there. Intima media thickness is the earliest biomarker of stroke. If we want to monitor somebody for stroke from the age of 30 years, at that time he doesn't have plaques. It is just that his endothelium of the carotid artery is little thick. It's a marker, it's called intima media, and 18% of the people who are more than 18 years, we found their intima media to be thick. It can be very nicely here. On the right side, this is a normal intima media here, less than 0.8 millimeters, and this is an enlarged intima media, which you can see. It is thick here. And then one thing one of the things which is always of interest is that which plaques are prone to rupture and which plaques are stable. And again, imaging helps us in these patients. This is again a Doppler study. Echolucent plaques are thought to be prone to rupture. It represents blood, whereas echogenic plaques are hard. They are full of calcium. They may not rupture. So again, we can take the help of technology, Doppler technology, to know that which plaques are vulnerable to rupture. But the latest in this field is the MRI imaging of the carotid plaque, and I'm sure Ram Mohan knows much more about this, which we'll hear from him in subsequent lectures. You can see here, this is plaque imaging. You can see in all these panels, the whole plaque, you can see this lumen has become eccentric because one side of it is completely occupied by the plaque here, you can see, and lumen has become eccentric. And this is a very beautiful picture of plaque imaging where you can see ulcer. And I know Dr. Reddy is very interested in these ulcers, because even if the stenosis is less than 50%, if there is an ulcer there, it is prone to cause strokes. And now we have got a technology where you can actually see these ulcers by the MRI, advanced MRI technology. Then coming to the intracranial large artery disease, it's a very common disease here, and most of our strokes are because of this intracranial disease, which you can see here, these stenotic lesions. And again, recently, actually, a few years back, we did a study by which we validated transcranial Doppler with MRA to diagnose these stenosis by one of our doctors who practices in Visakhapatnam now, Devudu Babu, did good work. And based on that, we did again another study with ICMR to find the prevalence of middle cerebral artery stenosis in asymptomatic subjects in our population. And we found that 7% of the people who are completely asymptomatic in our population have got middle cerebral artery disease. 7% is a huge number in asymptomatic people. So intracranial disease is more common than extracranial disease, even in asymptomatic people in our own population. This was done by Sujay, who is now in Nellore. Now, how do we know that whether this plaque is sending any emboli or not? Again, transcranial Doppler helps there. You can see along these spectra, there are some high intensity transient signals. These are high intensity transient signals. and these represent emboli. Dr. Reddy is very fond of them. Many times he has sent patients to us for this. We had machines, both of them are broken down now. So I have sent it to Yashoda to get it done, and this has come from Yashoda, where they have shown very nicely that some nice signals are coming. So transesophageal echocardiography, this is TCD, transcranial Doppler. But even in this field also, now there is a MRI is playing a great role by seeing the intracranial plaque imaging. Extracranial is now old. Now it is the intracranial plaque imaging, and I am sure Rammohan will be very excited by that. So you can see here, we can see here there is a stenotic lesion here, but that is not enough. Now see here, you are seeing the plaque inside the vessel wall. You are seeing the plaque inside the vessel wall. You are seeing this is the vessel, and inside the wall of the artery, you are seeing the plaque. And this is the hottest thing at this time. If you attend any foreign conference in stroke, all they will be talking about is plaque imaging by MRI, where they give contrast agents, they see how much it is enhancing, and intracranial plaque imaging is the hottest topic in stroke right now. So that again, it's a biomarker, it's a radiological biomarker that okay, this lesion is hot, it can rupture, treat it. Other lesion is cold, you can just take it coolly. Now, silent infarct is another biomarker, which you can see here in the CT scan. People with more silent infarcts are more prone to develop strokes in future, and microhemorrhages is another biomarker of future hemorrhagic stroke. Here there are many studies which have shown that if you have 2 or 3 microhemorrhages, it is not significant. But if you have more than 10 microhemorrhages, more the number, more the chances of their, chances of bursting in future. Many people harbor these microhemorrhages, and when they have any systemic disease like liver disease or kidney disease, or they take some drug, it can just become a massive hemorrhage. In fact, I know some people who had this recently. Small vessel disease, you can see this leukoariosis, it's also a weak marker of future stroke, not that strong, but it's also. So I'm trying to give you an idea about the radiological biomarkers of cerebrovascular disease, which should alert us to the possibility of a future stroke. But the main thing and the main interest in the world at this time is about the blood biomarkers, and they leave a lot to be desired. In fact, when I went through the literature, there are so many of them that it's impossible even to remember them. Diagnostic biomarkers for stroke, so many of them. Etiology biomarkers for stroke, so many of them. Prognosis biomarkers for stroke, so many of them. Do you think it is possible to remember each one of them? I have just selected 5 or 6 superstar biomarkers on which there are full articles. First is brain natriuretic peptide. It's called brain peptide, but actually it comes from heart. It comes from heart. When the myocardium is stretched or there is volume overload, it is secreted into the blood, and it is thought to be a biomarker of the cardioembolic stroke. And cardioembolic stroke is a very hot topic, because in America they say that every stroke is cardioembolic until proved otherwise. So many of the cryptogenic strokes where you don't know the mechanism, it is said you should do their Holter monitoring even for 1 month, even for 6 months, till you find a paroxysmal atrial fibrillation. Now it's not practical to take all stroke patients and do their monitoring. So this may help there, that if they have got high brain natriuretic peptide, then there is a possibility that they may be harboring a cardioembolic source. The second superstar biomarker is C-reactive protein, our own humble C-reactive protein. Well, it's an acute phase reactant which is basically produced by liver and regulated by inflammatory cytokines. But what is important is that it has been found that in carotid atherosclerosis, CRP levels are very high. So if you are worried whether the carotid is active or not, whether it's prone to rupture, they propose that you should do CRP levels in these patients. Okay. The third one is lipoprotein associated phospholipase A2. In 2 separate studies, elevated lipoprotein activity was associated with a large artery atherosclerotic mechanism causing the cerebrovascular event. So therefore, whenever we have got a patient with a large artery disease, if we send these biomarkers, they are prone to rupture and cause the damage. This one is very important thing, matrix metalloproteinase N. This is a particular substance which is thought to be responsible for causing rupture of the plaque. So if it eats the tissues, it eats the blood-brain barrier. So therefore, if you have got high levels of matrix metalloproteinases, the carotid artery is prone to rupture, the plaque is prone to rupture and causes stroke, and also this has been found to be associated with a high chance of bleeding after IV thrombolysis. This is elevated levels of this metalloproteinase in patients with more than 50% carotid stenosis are associated with twofold risk of ipsilateral stroke or cardiovascular death. D-dimer is my personal favorite because it is increased in the CVT. In any venous stroke, whether it is DVT or pulmonary embolism, whenever we have doubt whether it's a venous stroke or whether it is tumor, we send D-dimer. I think Vijay Sarthi will be interested in this. Because many times we have a problem, is it a tumor or is it a CVT? So D-dimer is there. But D-dimer also is particularly been found to be associated with cancer-related hypercoagulability, which is a rare cause of stroke. Fibrinogen. It's very important. Interestingly, it has been found that after we give TPA, the first thing which TPA does is brings down the fibrinogen levels. TPA effect is directly related to fibrinogen. Therefore, when a TPA person bleeds, we have to give him fibrinogen and bring up the fibrinogen levels. We monitor TPA bleeding by fibrinogen. Cellular fibronectin. The risk of high cellular fibronectin predicts the risk of hemorrhagic transformation after TPA. So how nice it would be that if we can take this fibronectin and if it is high, we will say, no, you don't qualify for thrombolysis because you will bleed. That is the dream. S100 calcium binding protein B. It has been identified as a predictor of hemorrhagic deterioration after thrombolysis in ischemic stroke. Okay. Copeptin. Copeptin appears to be a marker for post-stroke complication, particularly infection. So in my hospital, if there was a chance, I would send copeptin on all my patients in the ICU, and if it is high, I will take them out of ICU and keep them in some general ward because ICU is full of infection. Glial fibrillary acidic protein. Several studies have demonstrated that these levels are significantly higher in intracerebral hemorrhage compared with ischemic stroke. These are all the inflammatory biomarkers. You know what we discussed in pathophysiology, these IL-6 and CRP and ICAM and VCAM and CD4, everywhere they are found to be significantly more in the stroke patients compared to the controls. So this is the biomarker model. This is the dream of a neurologist, those who deal with strokes. If you talk of that, what is the dream that we are trying to create with biomarkers, this is what it is. It will help us in the early detection of subclinical pathology, radiological as well as blood biomarkers. It will help in the diagnosis of acute and chronic symptoms. It will help in risk stratification. It will help in monitoring disease progression or response to therapy, and it will help in selecting the therapy like thrombolysis. And overall, it will be improved patient care. It is the biomarkers model. It's a dream. But like most of the dreams, it's not fulfilled as yet. So these are the unmet needs. Why this dream has not been fulfilled? If I showed you so much of data and so much, then why it's not fulfilled? Because numerous biomarkers and panels of biomarkers have been studied to improve the early diagnosis, but none have sufficient sensitivity or specificity for routine clinical use. They are too general. CRP helps in stroke, but CRP can make common cold also. That is the problem. And the biomarker guided therapies have excellently succeeded in animals, but failed in the real world in human beings. I think for the last 20 years, journals of neurology and stroke, if we take every journal, there will be some of the agents, anti-inflammatory and all, right, from enonilamb and what all, and finally ends with succeeds in mice and rats, but not in human beings. Now see, this I am giving you just one example of these anti-inflammatory agents in mice. Everywhere there is a reduction in infarct. Reduction, increased flow, reduction. 90% success in animals, 90%. Reduction, increase, reduction. But then come to human beings. Human clinical trials of these anti-inflammatory effect, no, not applicable, no. So why these trials have not succeeded in humans? Because finally our aim is to treat humans, not animals. One is that the endpoints vary between humans and mice. Endpoints after stroke. Human beings have to walk, they have to think, they have to see. Animals have to just move a little bit of his toe or thumb and we say he is cured. And one intervention does not address all mechanisms. You may control inflammation, but stroke is not only inflammation. There are a lot of other influences. And there was a non-uniform window period in all these anti-inflammatory, right from 0 hour to 24 hours. So that can again mix the results. And the most important and interesting reason why they have not failed in animals, unlike human beings, is these experiments are done on healthy rats. They have got good bodies, good blood supplies, unlike worn out human beings who get the stroke. So the basic model is wrong. The rat is healthy, well fed. You have to see those rats in University of Hyderabad. A well fed, nice rat. Then they cause a stroke in them, but they have got good mechanisms to cope. But human beings are 90-year-old with a lot of damage and frayed arteries and all, they cannot sustain that. So the model itself is wrong. There are many people are suggesting you should have primates. They are near, but again primates will not be stressed. Only human beings are stressed. So this is one cartoon from Stroke Journal. He is saying that for doing these studies, you take unhealthy old rats, make them smoke for quite some time, let them eat Cheetos, chips, ice creams, and give them alcohol, and prepare them for a year or so. And then you see these are unhealthy old rats. They are survivors of the rat race. And then cause stroke in them. And then see if it works or not. That is likely to work in human beings. And this stroke I have taken from Stroke Journal. Right? So what we need is a reliable biomarker. This is what we need. We need a biomarker which is objectively measured, which is evaluated as an indicator of normal biological process, pathogenic process or pharmacological response to a therapeutic intervention. We need a highly sensitive or highly specific biomarker. If we want CRP, we want CRP only for carotid, not for common cold. We want a biomarker which reflects disease severity, abnormal physiology or biochemistry. And we want those prognostic biomarkers if that level is clinically actionable. Just to say it is bad doesn't help anybody. It is bad, therefore this is to be done. It's bad, therefore this is what we need to give. These are from American College of Cardiology recommendations. Otherwise they have said that don't do this research. Your research should be geared towards finding these outcomes. It should be used as a basis for specific biomarker guided therapy, not just theoretical exercises. And we should use the biomarkers where biomonitoring during treatment is an effective surrogate of improvement, right? So therefore, if a patient's biomarkers have decreased or increased, they should reflect that the patient has improved, even if it's not visible clinically at that time, but they should be true surrogate markers. So what are the future directions, right? Well, work. There is a need for good quality studies, and the patients should be prospectively collected, not biased patients, not biased investigators, consecutive patients, recruit patients in whom non-expert clinicians suspect stroke, because that is the real world. In the real world, it is not the stroke specialists who treat stroke, general physicians treat stroke. So recruitment should be like that, and so on and so forth. Particularly for biomarkers, fully describe the laboratory technique for marker measurement so that it is open to everybody, it's transparent. Measurement blind to clinical status, validate biomarkers and diagnostic threshold, give numerical value of threshold, reporting, show raw data wherever possible, and follow the standard STAD guidelines when preparing. These are the standard guidelines which have come after neuroprotection therapy failed. So this is the future. If the biomarkers have to be developed, new ones have to be studied in a multimodality clinical trial. The clinical trial standard has to increase. They have to be multimodality, and there are three components of that. One is biomarkers, blood biomarkers, second is novel imaging modalities, and third is clinical endpoints. So when we do stroke research, it is recommended that all three you should study. Study clinically, study imagiologically, and study blood. Multimodality clinical trials. And that will give a biomarker validity in the real world, in the clinical context. I am a big fan of auto rickshaws, and I think if we have to solve transportation problem of India, auto is the answer. It is small, it can go through streets, it is economical, right? But the problem with auto is there's a lot to be desired. It can't run fast. See, I have to go to airport every Saturday. It can't take me to airport. And although it is inexpensive, yet for me it's expensive because meters don't work, and that fellow charges whatever he wants to do. and sometimes it can collapse and turn turtle also. But that has not, I have not given up hope on autos. In spite of these lacunae, we need a better model. Thank you very much. Any comments or questions?